In today's lecture, I'm going to cover the management of patient with mobility disorder. It's not the whole mobility for this semester, but it's a part one mobility disorder that we're going to cover today. In going over today's lecture, we're going to cover the assessment of musculoskeletal disorder, diagnostic studies that are related to musculoskeletal disorder, and also nurses' role in terms of diagnostic studies. And also we're going to cover arthroplasty or joint replacement, which we're going to cover two parts of the arthroplasty. Most common arthroplasty that usually are done are knee replacement or knee arthroplasty and hip arthroplasty. Also, we're going to talk about the amputation, contusion, sprain, and strain. Just a little bit going over the musculoskeletal system, I would like to just as a refreshing your mind, go over the musculoskeletal system that which includes the bones, joints, muscles, tendons, ligaments, and bursa of the body. The function of these parts are highly integrated. Therefore, a disease in or an injury to one part or one component of this system will adversely affect the other parts. I give you an example. If there is an infection in the joint, it causes degeneration of the articular surfaces of the bones within the joint and the local muscle atrophy. Going back to the function of the musculoskeletal system, hope you guys all remember from the A and P, the health and proper functioning of the musculoskeletal system are dependent on the other body system as well. The musculoskeletal system has a very, very important function, which includes providing protection of vital organs, including brain, heart, liver, kidney, lungs, and spleen. Also, musculoskeletal system provides a solid structure to support body shape. It also makes mobility possible. If you like to refresh your knowledge about the anatomy and physiology of the musculoskeletal system, you can study from chapter 39. Now we're gonna talk about a little bit about the assessment of musculoskeletal system. When you do an assessment of musculoskeletal system, make sure to collect information about the patient health history and the patient musculoskeletal disorder. So when you get the health history, make sure to get the history of any chronic musculoskeletal disorder. Write down everything, all the significant health history in diagnosis of medical problems. You can find some of these information from the patient chart. And noting all these problems can lead to have a better care plan to prevent patient from any further complication. And when you do the musculoskeletal assessment, make sure that assess the pain. The pain is the most common and primary symptom, and one of the diagnostic studies or indicators of many musculoskeletal disorders. So usually patients who have MS disorder or musculoskeletal disorder, they complain of pain a lot. You can check the patient or assess the patient pain with the range of motion, active and passive range of motion. If the patient is able to move their joint and limbs, or any joint and any part of the body, ask them to move and ask them if they have any pain, or if they are not able to do it, passively do range of motion, stretching, and note any absence of feeling. Sensation is already should be assessed, and usually in some cases the patient have altered sensation associated with this system disorder. Ask the patient for any numbness or tingling in the lower or upper extremities, in the fingers, in the toes. Usually the numbness and tingling in this area indicates a peripheral neurovascular dysfunction along with musculoskeletal dysfunction. So be very mindful about assessing the patient in this area. Check the circulation and check the color, note any paleness, cyanotic or motile. Temperature, make sure to check the temperature for any coolness. Check the capillary refills, motions, for any weaknesses, for any paralysis. Check the sensation for paresthesia, unrelenting pain, pain on passive stretch, and absence of a feeling. A technique that use the technique of inspection and palpation to evaluate the patient posture, gait, bone integrity, joint function, and muscle strength and size. In addition, assessing the patient the gait and posture, make sure to assess the skin and neurovascular status in that area, which is very, very important part of the musculoskeletal assessment. Keep that in your mind, that a special precaution must be taken when assessing a patient who has sustained a trauma or complaining of pain. Be very gentle with that area, because I have seen new nurses or a student who just learned the assessment and learned about the palpation. Usually they are a little bit harsh on patient. They do instead of gentle palpation, and they are not very gentle, so it puts lots of pressure or pain in the patient. Going to the gerontologic consideration, multiple changes in the musculoskeletal system occur with aging and brings very, very much complaints of pain and most importantly, joint limitation, they not being able to move their joint. There is a loss of height to maybe as a result of osteoporosis or kyphosis. A thin intervertebral disc also can cause the loss of height, and also flexion of the knee or hip also can cause the loss of height. Women usually lose more bone mass than men. Also, by aging, the bone changes in shape and have reduced strength. A fracture are common in elderly, increased inactivity, and also diminished neuron stimulation and nutritional deficiency also contributes to the loss of muscle strength as well. Older adults may suffer from chronic musculoskeletal disorder that limits mobility and interferes with their ability to perform self-care and doing their own activity, daily living. And as a result of losing their function and not being able to do their activity, daily living, they may go to the grief and depression and because of the loss of independence. Despite these changes, that many effects of aging can be slowed if the body is kept healthy and active through positive lifestyle behaviors. So as soon as we find out the problem, we can help them. Going over the diagnostic evaluation or diagnostic study relate to musculoskeletal disorder, there are many imaging studies that could be done. And the first one is X-ray, which is the primary diagnostic procedure for musculoskeletal disorder. If there is any fracture, they will do it. They take patient should have an order for an X-ray in that affected area. Also, checking the muscle weakness is another indicator for to evaluate the conduction of electrical impulses, which is called electromyography, that could be done to identify any muscle weakness or conduction. Impulses conduction. Arthroscopy assesses the condition of a joint and allows the repair of the tears and other joint defects. Musculoskeletal diagnostic procedures that nurses should be very knowledgeable about are arthroscopy, bone scan, dual X-ray, absorptionometry scans or DEXA, electromyography or EMG, and nerve conduction studies. Other diagnostic procedures that help detect joint problems and identify musculoskeletal structures are X-ray studies, ultrasound, computed tomography, scans, or CT scans, and magnetic resonance imaging or MRI. So, talking about all of this, our beautiful future nurses and compassionate future nurses must be very, very knowledgeable about this procedure in terms of preparation of the patient, post-procedure monitoring, and educating a patient for discharge and follow-up. All right. I give you a little bit of information, and expectation is that you study by yourself and find it in chapter 39 for more details. One of the studies that usually interferes with some stuff in the patient is MRI. So be cautious about the patient who has an order for MRI. Jewelries, hair clips, hearing aids, credit cards, magnetic strips, and other metal containing objects must be removed before the MRI. It can become dangerous. Projected object can cause burn also. Credit cards may be erased, and non-removable cochlear devices can become inoperable. Let's see. Transdermal patches should be removed. What else I have? Tattoos that was done maybe 50, 60 years ago. They have a little bit of aluminized layer, so they should be cautious, cover it up. You have to ask the patient for all these objects. One more thing that you need to be cautious if the patient has any study order, a study with the contrast. So if a contrast agents will be used for CT scan, MRI, or arthrography, nurses should carefully assess the patient for possible allergy if they have allergy to the iodine or any shellfish. If the patient had previous study and they are aware, if they don't, so it's your role to assess the patient post-procedure for any sign and symptoms of asthma and all of this, or problem with the breathing. In addition, you should be aware that risk factors for adverse reaction to these procedures or contrast is if the patient had a history of asthma, if the patient is allergic, diabetes, renal insufficiency, and cardiac disease. The patient with cardiac disease are not a good candidate also. And finally, you must assess risk of pregnancy before decisions are made regarding the use of contrast materials. So make sure to assess the patient for this, and also a study from the book that for the assessment for post-procedure. Arthroscopy is a procedure that allows a direct visualization of a joint to diagnose joint disorder. Treatment of tears, defects, and disease process may be performed through this procedure. And this procedure is performed in OR under the sterile condition. Sometimes they do it under the they take the patient to radiology, but it has to be done under the sterile technique and condition. Injection of a local anesthetic into the joint, or sometimes a patient goes under the general anesthesia. After the procedure, the puncture wound will be closed with a very small adhesive strip. Usually, complications of this procedure are rare, but may include infections, hemarthrosis, which is bleeding into the joint cavity, neurovascular compromise, thrombophlebitis, stiffness, fusion, adhesion, and delayed wound healing. So, what you need to do as the nurse, you need to make sure that the joint should be wrapped with the compression dressing to control the swelling. Ice may be applied to control the edema and discomfort. This is important to monitor neurovascular status. So as we talked about, the neurovascular status is checking the patient perfusion, extremity to affected extremity, and also sensitivity and motions as well. Any numbness, any tingling. The nurse should educate the patient when the patient can resume to activity, and what weight-bearing limits to follow as prescribed by the surgeon. So it's not a definite for that when the patient can get up and put the weight on that affected area. Usually the surgeon will write the prescription related to that specific patient to make sure that when they can weight bear. Usually applying ice is for the first 24 hours. If they are in pain, instruct them to take the pain medication. If there is a prescription for a splint or a sling, apply them. Maintain activity restriction based on the prescription. And also, if they need to use crutches, there will be a prescription for that. As I said again, make sure to check the neurovascular system or status for this patient on the affected site. Monitor the color, temperature, pain, swelling, redness, any fever and sensation for infection, and tell them that to notify the provider for any changes. We're going to talk about arthroplasty, and we're going to cover two arthroplasty in this lecture. You can find the arthroplasty or joint replacement on chapter 40. I would recommend you do not follow the pages that we put on weekly schedule, because it have caused some confusion with the student, because the pages that we include to the weekly schedule is from the version that we have. We have a version of electronic. Sometimes it doesn't match with your version of hard copy, and also some of the students do have different edition of the textbook. So make sure that follow the topics. Talking about the arthroplasty, it's a surgical removal of a diseased joint. Okay. Usually the patient with severe joint pain and disability may go under this procedure, joint replacement. The conditions that are underlying factor that the patient goes under the joint replacement are joint degeneration, including osteoarthritis, rheumatoid arthritis, trauma, and congenital deformity. In some fractures, like the fracture of femoral neck, of the hip, of the leg, may cause interruption of the blood supply and cause vascular necrosis, which is a death of tissue due to insufficient blood supply to that area. So make sure to be aware that is one of the symptoms for femoral neck fracture. So this is one of the areas that you need to study on chapter 42. Find the femoral neck fracture and learn about the femoral neck fracture sign and symptom, and patient's care and nursing intervention for that area. So management with joint replacement is most of the time elective, and it is called open reduction internal fixation, which is usually called, they call it ORIF, O-R-I-F. So it is open reduction. That means they open that area. So this is a knee. Before is a degenerated knee in this area, and also after the surgery. Basically, the joint that are usually replaced include the hip, knee, and finger joint. In some cases, there has been some shoulder, elbow, and wrist and ankle replacement, but it's very rare. It's less frequently. Arthroplasty is as I said, is a removal of diseased joint, and it is replaced with a prosthetic or artificial material, which usually is made of either metal or plastic. With joint replacement, patients may expect pain relief the pain that the patient had before the surgery, but there's still some surgical pain, but the pain that they had with the motion is going to be relieved. And also it improves the functional status of the patient and improves their quality of life. The range of these improvements also depends to the patient condition preoperatively, and the goal is for both even knee and hip to eliminate the pain and restore the joint motion so patient can have a better life, quality of life, and be more active in mobility or activity daily living. We're going to talk about the post-surgery of arthroplasty, either the hip arthroplasty or knee arthroplasty nursing intervention. The nurse should monitor the post-surgical bleeding and assess the patient for any sign and symptom of deep vein thrombosis and implement the prophylactic regimen for deep vein thrombosis. Usually is administration of low molecule heparin and SCDs, and also slight range of motion on unaffected side, and also prevention of infection and management of the pain after the surgery. As I said before, the patient pain with the motion that the patient had in the preoperatively will be reduced, but the patient still has the surgical pain and it should be managed. If the patient had a total hip arthroplasty, make sure to read the nursing intervention in that area. Usually it is called THA, total hip arthroplasty. It is usually replaced when the hip of the patient severely damaged or fractured. Usually for damage, disease that cause damage to the hip includes osteoarthritis, rheumatoid arthritis, and also, as I said in the past, neck femoral fracture. In some cases, the patient had surgery in the past, like had a hip replacement or knee replacement, and it failed. So in that cases, they also take the patient for the management and replacement. So in some cases, the patient had the arthroplasty before in the past and it failed and it's not functioning, it's very painful, so that cases the patient needs to have second surgery. Be aware that the nurses, as a nurse, to monitor for a specific potential complication related to the total hip arthroplasty. Complications may occur include dislocation, hip prosthesis of the hip prosthesis, and excessive wound drainage like bleeding, and DVT, VTE infection, and heel pressure ulcer. Make sure to read the chapter 40-6 for more information in that the chart in chapter 40-6 for more information. The nurse also should monitor for complication associated with immobility. So what are that? Complication associated with immobility. I'm sure you guys remember from the first semester about mobility and immobility complications. One of those immobility complications are pneumonia, one is DVT, and bed sore, and all of this. So make sure when you study, bring all those previous knowledge to this, and add this knowledge to your previous knowledge in 121 and 113 that you learned about the assessment of musculoskeletal and also the complication associated with immobility. The long-term complication related to this surgery includes heterotopic ossification, which is the formation of bone in pre-prosthetic space, and also a vascular necrosis. As I said, the pressure, too much pressure to the vessels cause the necrosis of the tissue around those area, and also because infection can cause loosening of the prosthesis. In the cases of the infection, if the patient get infected in those either knee or hip, the treatment for this is to remove the prosthesis first before they start the antibiotic therapy. So it has to be removed before the therapy, and then they will think about that if they can put it back there later or do something else. But for treatment of infection, the prosthesis should be removed first. Let me go to the more complication. We talked about venous thromboembolism, which also you've learned about the venous thromboembolism or deep vein thrombosis, which can also lead to pulmonary embolism. You've learned the DVT, you've learned about the pulmonary embolism sign and symptom. Make sure to learn about them from the book and see what is the nurse's role during before to prevent from DVT, and when the actual problem is there, what the nurses should do. As you know, for prevention, as I said, is anti-coagulant therapy and SCD, and also a slight range of motion to prevent from deep vein thrombosis. The next one is to prevent from dislocation of the hip prosthesis. Make sure you can find the information in chapter 40, chart 7. It takes time to a hip prosthesis to stabilize after the replacement. It is very important to follow instruction for proper positioning, so to prevent from the dislocation. This is a very serious complication for surgery and causes pain and loss of function, and requires reduction under the anesthesia to correct the dislocation. So be aware of this complication as a severe complication or serious complication. The best suitable position for this patient includes abduction, neutral rotation, and flexion of less than 90 degrees. When you are seated, the knee should be lower than the hip. So make sure to educate the patient, and also make sure when you take care of a patient with hip arthroplasty to keep that in your mind when you reposition the patient or when you get the patient out of the bed, to make sure to position them correctly. Or if someone else is positioning them, just observe them to make sure they are properly position the patient. To educate the patient, when you discharge the patient, make sure to teach them or educate them about this displacement, the hip dislocation. Make sure they teach the patient to keep their knees apart and at all times. They should put a pillow between the legs when sleeping. and tell them to never cross the legs when they are seated. Ask them to avoid bending forward when seated in a chair. They should avoid bending forward to pick up any object on the floor. Teach them to use a high-seated chair and a raised toilet seat. Make sure to educate the patient. Do not flex the hip to put on clothing such as pants, stockings, socks, and shoes. Make sure the position to avoid after total hip replacement are shown also in the textbook. Go ahead and take a look in the textbook and learn about this important nursing intervention. For the total knee arthroplasty, also there are nursing intervention that should be done for total knee arthroplasty. The patient provide post-operative care. If we go to the previous slide, you can see the patient can develop DVT, the patient can develop infection, the patient is at risk for DVT, and but the patient is not at risk for dislocation as the hip dislocation. Make sure to prevent from infection. Check the patient, monitor the patient vital signs and the site for any sign of infection. Prevent for any post-operative complication, and you need to make sure the patient is passively moving the knee. So usually there is a device that is placed in on the patient knee, and it gives the patient passive range of motion and to prevent from the stiffness. Flexion of the knee is limited, so be careful about the flexion. Avoid any flexion to avoid any flexion contracture in the legs. Avoid using a knee gauge and pillows placed behind the knee. The patient can have a pillow under the lower calf and foot to have some slight extension on the knee, but no flexion. In the patient with knee arthroplasty, we can apply ice or cold therapy to the incision area. Monitor the neurovascular status of the surgical extremity every 2 hours and make sure to document it. It's very important. Neurovascular assessment, it's very crucial in these cases, in both cases, knee and hip arthroplasty. Assess the patient for any bleeding and also any complication assessment. So the patient can develop the pneumonia as well. Make sure to check the patient respiratory condition. Any patient after any surgery under the general anesthesia or any other surgery, they can develop the pneumonia. So make sure the patient is taught the coughing and using a spirometer is very important. Follow the post-op care from the first semester that you learned about post-op surgery with the orthopedic patient as well. The next topic that I'm going to cover today, it's amputation. As you guys know, the amputation is a removal of a body part. Amputation of lower extremity is necessary when the patient has peripheral vascular disorders. So this is very important. Often patient with the diabetes mellitus or the patient with vascular disorder ended up with the gangrene of the lower extremity and poor perfusion and finally death of the tissue. They end up with the amputation. So these are the different risk factors that are causing amputation, elective amputation. In some cases, it's a trauma like a crushing injuries, burn, frostbite, electrical burns that are not elective amputation, but this condition, like the trauma, is emergency amputation. Amputation is done to relieve the symptoms, to improve the function of the individual, and to save or improve the patient's quality of life. In some cases, if there is infection, it can cause a fatal death with the septicemia or septic. So basically, in many cases like this, the decision is made to save the patient life. In some cases, in the trauma cases, the bleeding is severe and they have to do the amputation to save the patient life. And in the elective condition is to improve the quality of life. If the healthcare team communication is positive and they have a positive attitude towards the patient adjusts to amputation more readily, and actively they participate in the rehabilitation plan, and they learn how to modify the activities and how to use the different assistive devices for their own activity, daily living. So it is important to have a positive attitude towards patients with amputation to be able to get their trust and involve them into their health. What we plan for a patient who actually not planning is in what condition, when you assess a patient with the poor perfusion, what would you find as data or symptoms and signs that places the patient for amputation. The patient usually with the decreased tissue perfusion, they complain of pain, they have a history or injury or disease process for amputation, like the diabetes or like vascular disorders. The altered peripheral pulses also are another symptom that you can find out during your assessment. If the patient peripheral pulses are non-palpable, you can use a Doppler to assess the patient's pulses to find out if they have a pulse present or absent pulse. You can find the difference between the temperature of the extremities. You can check the color of the extremities, and in the extremities that are black indicates the gangrene, cyanosis, and indication of compromised vascular system, which results in amputation. The presence of any infection and open wound that is not healed after a while also is a sign for amputation. Lack of sensation in the affected extremity also is another tissue perfusion issue that will requires amputation in some cases. What is the level of amputation? Usually the amputation is described in regard to the extremity and whether they are where they are located. If they are above or below under the joint, a specific joint, they're called. If you look at this patient's leg, If it is above the knee joint, is called above knee amputation. This is the knee joint, and if the patient has amputation below the knee joint, is going to be a below knee amputation. And also some cases they have minimal infection in their toes. They start amputating the toes and then end up with the ankle area, which is the seam area. In upper extremity also, it could be that the joint of elbow, which is above elbow and also below elbow. You can see the shape that after the surgery, which is the goal to keep these shapes for the prosthesis. What we can do for a patient, or what we should do for a patient after the amputation, first is relief of pain. Patient has a surgical pain, but there are some cases that the patient has phantom or phantom limb pain, which can start from right after the surgery, but it can start 10 years after surgery, but it can even stay as long as the patient lives, and they still complain of phantom limb pain. And this is the pain to the site that is amputated, and the patient still feels that area is there, and they feel the pain like if the patient had a below knee amputation. They still feel the toes pain and ankle pain and pain they had previous to surgery. Promoting a wound healing is very important. The wound healing is important for using of prosthesis after the healing and preparation of the scalp, and make sure that the patient gently handle the patient residual limb. Make sure use your palm of your hands to reposition the residual limb. Check the patient for any edema every 8 to 12 hours in that affected limb. Assess for adequate blood supply. Change the dressing when they are soiled. Body image is very important. So the loss of a body part, it may come like a shock for the patient, and then patient behavior may changes, like crying, withdrawing, lack of interest, or anger. Patient can express all these feelings like depression, fear, helplessness. Helping the patient to cope with this loss of the limb is a long process, and since the patient goes through the grieving process. Usually the nurse creates an accepting and supporting atmosphere for these patients with the body image issue and grieving and all of this, for the patient and family, to encourage the patient and family to express and share their feelings with the patient and work through their grief process. As we know, amputation will affect on patients' ability to provide adequate self-care and their activity daily livings. The patient should be encouraged to be an active participant in self-care. So if the patient lost the lower extremity, make sure to ask for them for participation to doing their hygiene for upper extremity. So involve them to the care. So the nurse must maintain a positive attitude and encourage the patient for a positive attitude to minimize the grieving and encourage the patient for learning process. Proper positioning for the patient is very important. So for the patient with amputation, positioning is different from the hip dislocation and hip arthroplasty, but the patient with amputation can develop flexion contracture. So proper positioning will prevent the development of the hip and joint flexion contraction. Usually it happens with the patient with the lower amputation. Abduction, external rotation, and flexion of the lower extremities are avoided. The patient with the above knee amputation may need to lie on prone position 20 to 30 minutes 3 times a day to avoid the hip contraction if appropriate, because in some cases if the patient has respiratory disorder they cannot be placed on that position. So make sure you know the patient condition, respiratory condition, and if proper for that patient, put them in prone position 3 times a day at least. Okay, I have to go back. Helping a patient to achieve physical mobility with the patient with amputation is very important. Nursing action to prevent from the flexion contraction is a starting range of motion and exercise and proper positioning immediately after the surgery. To prevent hip or knee flexion contracture, avoid placing pillow under the stump and have the patient, as I said, lie down 20 to 30 minutes several times a day. Discourage the patient on prolonged sitting. Teach the patient to stand using a good posture with residual limb in extension condition. This also will help the patient in balance. If there is a cast or elastic dressing applied and it accidentally comes off, make sure that immediately wrap the residual limb with an elastic compression bandage. If this is not done, excessive edema will develop in a short time in that area, which results in delay in rehabilitation. And the nurses should notify the surgeon if a cast dressing comes off so the another cast can be applied promptly. The residual limb should not be placed on a pillow because it causes flexion contracture of the hip. So talking about contusion, sprain, and strain is very simple. Contusion is a soft tissue injury produced by blunt force such as blow, kick, or fall, which causes a small blood vessel to rupture and bleed into soft tissue. A sprain is an injury to the ligaments and tendon that surrounds a joint. It is caused by a twisting motion or hyperextension of a joint. And a strain is an injury to the muscle or tendon from overuse, overstretch, and overexercise, or over excessive stress to the muscle. The treatment of contusion, strains, and sprains is driven by severity of the injury and consists of protecting from further injury, which results in elevating the affected part, applying cold, and using a compression bandage. If you look at the rest ice pack compression elevation, we go with the rice The abbreviation R stands for resting, I stands for ice pack or cold pack. Compression bandage, you can see this is a type of compression bandage, and elevation to reduce the edema and pain. The protection from further injury is through the support of the affected area with a sling or a splinting. Resting prevents additional injury and promotes healing. Intermittent of application of cold pack during the first 24 to 72 hours after injury produces vasoconstriction, which decreases the bleeding, edema, and also discomfort. Cold packs should not be in place for longer than 20 minutes, as you guys know, which causes vasoconstriction and impaired tissue perfusion. An elastic compression bandage, as you see in here, controls the bleeding, reduces the edema, and provides the support for the injured tissue, and also elevation at or just above the level of the heart controls the swelling. If the sprain or strain is third degree, immobilization by a splint, brace, or cast may be necessary. So in that cases, the joint, they want to keep the joint stable, and so the joint won't move. Also, for the pain, we can use the NSAIDs, non-steroid anti-inflammatory drugs, or some kind of other medication like the Motrin to prevent from the pain, or manage the pain, not prevent from pain. Neurovascular assessment is important for this case. The patient should be monitored for the sensation. In this case, if you look at the toes should be monitored for the capillary refills, the temperature, and for the pulses and the cyanosis if the color changes. So it is called neurovascular status. You're going to check the circulation, motion, and sensation of the patient extremity frequently, usually every 15 minutes for at least for the first 1 to 2 hours after the injury, and then less in intervals. And we go to the every 30 minutes until it is stable. Any decrease in sensation or motion and increase in a pain level should be documented and reported as soon as possible or immediately, because it could be a sign of compartment syndrome, which is the complication of this bandage. It could be complication of the bandage, maybe so tight, or any internal bleeding or edema, which causes the compartment syndrome. We're going to talk about compartment syndrome more in mobility 2, and we go more in depth for the compartment syndrome. I think this is the last page. These are the chapters and the different topics that you can find. In chapter 39, you can find the assessment and diagnostic study. In chapter 40, you can find the joint replacement, arthroplasty, and in chapter 42, you can find the hip fracture and amputation to study. I think I'm done. This is the end of the slides and the lecture. Please let me know if you have any question. I will meet you in the on either Thursday or Friday in the classroom to discuss and have a flip lecture. So we are going to have a different case study to go over these patients' scenarios. I'm going to just share with you a few scenarios and go over the care of the patient with this type of mobility disorder. I will see you soon, and I wish you good luck in the semester.